Good morning, everyone. Myself, Aditya Sharma, roll number 3, and I'm going to present a seminar on the topic homeostasis. This is a topic number 1. So the questions covered in this topic are: define homeostasis in detail, describe different feedback mechanisms along with their examples. So, what is homeostasis? Homeostasis can be defined as maintenance of the constancy of internal environment of the body despite varying external conditions. In the 19th century, Claude Bernard, a French physiologist, he had following remarkable observations. First, the volume and composition of the fluid are maintained constant, independent of the changes in the environment in which the animal lives. Second, he designated the fluid, that is the ECF fluid in the body, as the internal environment to differentiate it from the external environment of the body. Third, he suggested that the ability to regulate internal environment is the major reason for humans and animals to live a normal life in spite of the changes and challenges imposed on them by the external environment. He noted the difference between intracellular and extracellular fluid and had proposed that the extracellular fluid is the internal environment of the body. So now, what will happen if there is going to be the failure of the homeostatic regulation? Stimuli or stress, it will lead to disturbance and there will be changes in the variable and it will cause the activation of feedback mechanisms. After the feedback mechanisms are activated, they're going to be effects or responses which will inhibit or stimulate of the variable. This will cause the return to homeostasis or the failure of which it will cause dysfunctions or diseases and will eventually lead to death. Some regulating systems and their functions. Respiratory system, it will cause the uh, homeostatic regulation of the CO2 content. Liver and pancreas cause the uh, homeostatic regulation of glucose. Kidney cause the balance of the concentration of the ions and electrolyte balance in the body. CVS maintains the blood flow and temperature regulation. Nervous and endocrine systems regulate the function of other systems as well. What are the components of control system? First is sensor to detect disturbance. Second, controlling center and the effector. So there are three types of homeostatic mechanisms: negative feedback mechanism, positive feedback mechanism, feed forward or anticipatory mechanism. We're going to be discussing negative and positive feedback mechanism in detail. Negative feedback mechanism. This is the most common feedback mechanism. The effect of controlling system is in the opposite direction of change in the parameter so that disturbance is minimized. Regulation of blood pressure by baroreceptors. So if there is going to be the increase in blood pressure, it is going to be sensed by baroreceptors that are present in the carotid sinus, and then eventually it's going to be decreased by the negative feedback mechanism. Regulation of hormonal secretion and the regulation of partial pressure of carbon dioxide of ECS. So what are the components of negative feedback regulation? If there is going to be disturbance, then it's going to be controlled variable at a set point. Then sensors monitor current value. Then through the feedback signals controller, it will compare if there is going to be error. Set point, which is going to be through the output effectors, it will produce a response in the effector, and then there is going to be correction. Characteristics of negative feedback mechanism. The disturbance is not corrected immediately. Latency and dead time, so the oscillations are possible. The disturbance is not corrected completely as well. So there is going to be residual change. What is going to be the regulation factor for this mechanism? It is going to be the change with regulation divided by change without regulation. Effectiveness of regulating system, that is the gain of system, is equal to correction applied upon residual change. Next mechanism is positive feedback mechanism. It is defined as the effect of regulating system which magnifies the error and sets in vicious cycle which stops only when there is going to be initial stimulus removal. So the example of this system can be if there is going to be 2 liters of blood loss, then ineffective heart pump, which will cause the decrease in BP, which will further decrease blood flow to the heart muscle, weakness of the heart muscle, and decrease heart pump further. This vicious cycle stops only when blood volume is corrected. For rapid magnification of basic corrective mechanisms. The prime example is Hodgkin cycles for sodium transport during action potential. Second is oxytocin secretion during parturition. This is the prime example of the positive feedback regulation. LH surge for ovulation. Enzymatic cascade for blood coagulation. And activation of digestive enzymes. Thank you.
So hello everyone, myself Manit, first year MBBS student at Shilal Bahadur Shastri Government Medical College, Nerchok, is here to give a brief seminar on the topic apoptosis. The questions to be addressed in the following seminar are: define and explain apoptosis, what is the significance of apoptosis, and what is the difference between the apoptosis and necrosis. Introduction of apoptosis. Apoptosis is the programmed cell death that has a genetic control. The genes of the own cells play important role in this programmed cell death. Apoptosis is a natural process, and the common examples of the apoptosis are death of a neurons in the central nervous system during brain development, and synapse formation is a common example of apoptosis. During fetal development, the degeneration of many tissues like web in the fingers is another example of apoptosis, and the most common example is that many blood cells like eosinophils will undergo the apoptosis. Mechanism of apoptosis. Mechanism of apoptosis includes, we will firstly discuss about the stimulus for the apoptosis. The activation of cysteine proteases in the cell called caspases triggers the apoptosis. Normally, the caspases are present in the inactive form in the cell and stimulated by external and internal stimuli. Thus, we can say that the stimuli is of two types, that is the internal stimuli or the external stimuli. We will firstly discuss about the internal stimuli. The mitochondria releases the cytochrome and a protein called SMAC that causes the activation of the caspase 9, which induces the apoptosis. In mitochondria, apoptosis-inducing factor is located in the intermembrane space that migrate to the nucleus and destroys the DNA. Now we will discuss about the external stimuli. External stimuli are the various ligands that bind with the cell surface to activate apoptosis. One such factor is the tumor necrosis factor that activates the enzyme caspase 8. The activation of the caspase promotes DNA fragmentation and the chromatin condensation. Now we will discuss about the common inducers of apoptosis, which includes the TNF family, whose full form is the tumor necrosis factor family, growth factor withdrawal, calcium, oncogens. Oncogens are the cancer-causing agents, nutrient deprivation, toxins, UV radiations, and the gamma radiations are some common inducers of apoptosis. Now we will discuss about the major steps in apoptosis. Firstly, there will be stimulus for apoptosis, which can be of two types, external stimuli and the internal stimuli discussed earlier in detail, which will activate the FS receptor activation, and cytotoxin T cells will get activated, which will further cause the semide generation and activation of caspase. Thus, the mitochondrial injury will be there and the damage to DNA will take place, which will lead to the formation of a protein called TP53 and the induction of cell death protein BAX. The cytoplasmic and chromatin condensation will take place and the formation of apoptotic body will be there, and thus finally the apoptosis will take place. And then the phagocytosis, which means the removal of apoptotic body, will take place. Here is the diagram to show that what is actually happening in the apoptosis. Here is the normal cell. Then the cell will undergo the shrinkage of cell as the water will move out of the cell and the chromatin condensation will be there, and which will cause the membrane bleeding, and the nucleus of the cell will collapse and bleeding will continue. Then there will be the formation of apoptotic body, and finally the lysis of the cell will take place and the apoptosis get completed. The physiological and pathological processes behind apoptosis. Apoptosis is a biological phenomenon which includes both physiological and pathological process. We will firstly discuss the physiological process behind the apoptosis. In the physiological process, there will be firstly the initiation of apoptosis, which will be transmembranous intracellular. The regulation of apoptosis will be there by BCL2 and other regulatory proteins, and the programmed cell death, that is the apoptosis, will take place. Apoptosis is a physiological condition. In human body, about 1 lakh cells, which is a very huge number, are produced every second by mitosis, and the similar number will die by apoptosis. Pathological process of apoptosis. Pathologic process are initiated by the following factors. These are the tumor cell death on exposure to the chemotherapeutic agents, the transplant cell death by cytotoxin T cells that cause the transplant rejection, cell death induced by viral infections as occur in the viral hepatitis, pathological atrophy following withdrawal of stimuli, for example, prostatic atrophy after orchiectomy, which means the removal of testicles. And the fifth point is the cell death induced by radiation, hypoxia and thermal injury, and the degenerative disease of CNS such as Alzheimer's disease and the Parkinson disease. Now we will discuss that what is actually the need of apoptosis. Apoptosis is needed for the proper development, example, the resorption of tadpole tail, the formation of the fingers and the toes of the fetus, the formation of the proper connections between the neurons in the brain. The apoptosis is needed to destroy cells, example, the cells infected with viruses, the cells with damaged DNA and the cancerous cells. Thus we can say that apoptosis also play an important role in our immunity. Significance of apoptosis. Apoptosis play an important role in the removal of unwanted cells, degenerated cells, potentially harmful cells and self-reactive cells from the body. Therefore, decreased apoptosis has been implicated in the genesis of malignancy and autoimmune diseases. Here is a brief chart to show the significance of apoptosis. When the apoptosis will take place in the excess amount, which it will cause the neurodegenerative diseases. And if apoptosis takes place in the deficient amount, it will cause the cancer and autoimmunity related diseases. Apoptosis is important for the DNA repair and wound repair and immune system maturation. It also plays an important role in the neural development and the morphogenesis. Now we will discuss that cell death can be of two types. Cell die by one of any these two mechanisms. The two mechanisms are the necrosis and the apoptosis. Necrosis is the death by injury and apoptosis is the death by suicide. Apoptosis and necrosis have very different characteristics which we will discuss now. Necrosis and apoptosis. Firstly, we will discuss about the apoptosis. In the apoptosis, the water will move out from the cell and which will cause the cell shrinkage and the chromatin condensation, which will lead to the cell bleeding, and finally the phagocytosis will be there, and in this way the apoptosis takes place. This will be helpful in development, tissue homeostasis, cell-mediated immunity and the hormone-mediated atrophy. Now we will discuss about the necrosis. In necrosis, there will be the reverse phenomenon as the water will move into the cell. The water is moving here into the cell as you can see here, and the cell will swell and it will finally blast. The lysis of the cell will be there and will release of the intracellular components will be there, and which will cause the physical trauma, and the complement mediated lysis, lytical viral infection will be there. Now we will move to the next slide. Here is a table to show a difference between the apoptosis and necrosis. The apoptosis is a physiological cell death and necrosis is the pathological cell death. Apoptosis is the functional form of cell death, whereas the necrosis is the accidental form of cell death. Apoptosis occurs under the physiological conditions, whereas the necrosis is seen under the pathological conditions. The main difference is the apoptosis is the ATP dependent process, whereas the necrosis is not dependent on ATP, means no energy is required for necrosis. In the apoptosis, cell shrinks and pulls away from its neighbors, and in the necrosis, cell swelling is a defining feature as discussed earlier. In apoptosis, there will be the rupture of the nucleus, and in necrosis, entire cell balloons and ruptures. In the apoptosis, no inflammation will be there, whereas the inflammation will be there in the necrosis. Apoptosis is induced by physiological stimuli, whereas the necrosis is induced by non-physiological disturbances like viruses, hypothermia, hypoxia, ischemia, and metabolic poisons. That's all for today. Thank you, everyone.
Good morning, my name is Maya, roll number 57.
My name is Komal, roll number 52.
Our topic is transport processes. The topics covered under this presentation are types of transport processes. First is passive transport, second is active transport, and third is vesicular transport. The transport processes. Passive transport is further subdivided into simple diffusion, facilitated diffusion, and osmosis. The active transport is further subdivided into primary active transport and secondary active transport. The vesicular transport is further subdivided into exocytosis and endocytosis. First, we will talk about passive transport. Transport is downhill. The substances pass through the membrane from both sides. However, the net movement occurs down the concentration gradient. That transport does not require energy in the form of ATP. Simple diffusion. The molecules move from the area of higher concentration to the area of lower concentration. Molecules move due to their random movement. Across a membrane, the diffusion of a molecule occurs when difference in concentration of a molecule exists on both sides of the membrane. Net movement of molecules ceases when the concentration of molecules on both sides become equal and a diffusional equilibrium is achieved. Examples of simple diffusion are oxygen, carbon dioxide, urea, ammonia, and ions. Factors that determine the rate of diffusion. The first is properties of the substance. The properties of the substance, which includes the concentration gradient of the substance. It is primarily responsible for the direction of transport of the substance. The molecule will move from their higher concentration to their lower concentration. The second is permeability of the substance. The ease at which the substance passes through the membrane. Factors that determine the rate of permeability are lipid solubility and the molecular size. Lipid solubility, permeability is directly proportional to the lipid solubility of the substance. Second, permeability is inversely proportional to the molecular size of the substance. Third, the charge on the molecule. Since membrane is polarized with its negative interior, cations easily enter from outside into the cell and anions in the opposite direction. Temperature. The rate of diffusion is high at higher temperature, as temperature facilitates the motion of molecules in the solution. Distribution of channels in the membrane. Permeability is directly proportional to the number of protein channels for the substance in the membrane. Pressure gradient. Diffusion is more from high pressure to low pressure, as the pressure causes greater number of molecules to hit the membrane. Properties of the membrane. Cross-sectional area of the membrane. Rate of diffusion is directly proportional to the surface area available for diffusion. Thickness of the membrane. Rate of diffusion is inversely proportional to the thickness of the membrane. Next is facilitated diffusion. Diffusion facilitated by the carrier proteins in the membrane is called as the facilitated diffusion, also called the carrier mediated diffusion, as the carrier proteins facilitates it. It is a downhill transport that does not require energy. Examples of facilitated diffusion are transport of various sugars into red cells, adipose tissue, skeletal and cardiac muscles. Features of facilitated diffusion. Faster rate of diffusion, saturation kinetics, competitive inhibition, specificity. Factors affecting the facilitated diffusion. Major factor is the number of carrier proteins available for the transport. Other factors which influence the facilitated diffusion are: first is properties of the substance and second is the properties of the membrane. Properties of the substance are effect of concentration gradient, permeability of the substance. Properties of the membrane are cross-sectional area of the membrane and thickness of the membrane. And the third one is osmosis. Osmosis is the process of movement of solvent from the solution with the lower concentration of solutes to the solution with higher concentration of solutes when both the solutions are separated by a semi-permeable membrane. Passage of solvent molecules is directly proportional to the solvent molecules on that side. Semi-permeable membrane allows passage of solvent, not of the solute particles. Osmotic pressure. Minimum pressure applied on the solution with higher solute concentration to prevent the osmosis. Further, this topic will be continued by Komal, roll number 52.
Active transport. The transport process that utilize energy and occur against the concentration gradient is the active transport. Active transport differs passive transport by its utilization of energy. And the common features of active transport are: first, uphill transport. Transport occur against the electrochemical gradient of the substance. Second, requires energy. Energy utilized for transport is derived from the breakdown of ATP, hence they are susceptible to metabolic poisons. Third, exhibit saturation kinetics. This is because of limitation in the rate of availability of carriers or supply of energy. There are two types of active transports which are as follows. First, primary active transport. Second, secondary active transport. First, we talk about primary active transport. Primary active transport is the transport mechanism that directly utilizes metabolic energy for the transport process, and the mechanism is operated by ion pumps. In this process, the solute is transported against its electrochemical gradient with the help of energy, and the energy is derived from ATP. The primary active transport system consists of the following pump: sodium potassium pump, calcium hydrogen pump, potassium hydrogen pump. First, we talk about sodium potassium pump. Sodium potassium ATP is present in all eukaryotic cells. This is an antipode that pump potassium into the cell and sodium out of the cell against their concentration gradients. And this antipode transport system is primarily responsible for maintaining the high potassium ion and low sodium ion concentration inside the cells by moving 3 sodium ion from the cell and take 2 potassium ion into the cell for each mole of ATP hydrolyzed. Second, calcium pump or calcium ATPase. It is present in the sacroplasmic reticulum in the muscle cells, which maintain the intracellular ionic calcium concentration. Third, potassium hydrogen pump. It is present in the cells of the gastric mucosa and renal tubules, where it causes the secretion of hydrogen ions. Secondary active transport. Energy created by sodium ion gradient is utilized for transport of other solutes, and the sodium ion gradient is generated and maintained by its sodium potassium pump. The transport system by itself does not directly utilize energy. It depends on the function of sodium potassium pump, and the transport of many ions and nutrients along the electrochemical energy gradient is accomplished by sodium ion dependent secondary active transport. Example of secondary active transport is reabsorption of glucose from kidney tubule and intestine. Calcium is exchanged from the cytoplasm of muscle cell from extracellular sodium. Vesicular transport process. Many substances are transported across the cell membrane by endocytosis and exocytosis. Endocytosis is the process of transport in which substance is taken into the cell by means of vesicle formation. And there are two types of endocytosis. First is phagocytosis. Phagocytosis is the process of ingestion of large particles or microorganisms by a specialized cell called phagocytes. Second, pinocytosis. Pinocytosis is the fluid phase endocytosis or cell drinking, by which substance in solution in extracellular fluid internalized to the cell. Exocytosis is the process in which the substance that move out of the cell are trapped within vesicles or granules, which fuse with the cell membrane and release their content into the extracellular fluid. By exocytosis, hormones, neurotransmitter, digestive enzyme and undigested foreign particles are released from cells. Thank you.
Good morning everyone. Today I, Suraj Bhardwaj, roll number 104, is going to present a seminar on the given topic, osmosis and Starling law for water and ion movement. So the questions to be discussed are: define hydrostatic and oncotic pressure, and how Starling law helps us to understand the mechanism of edema formation in the body. First of all, let us discuss what osmosis is. The phenomenon of movement of solvent from a solution of higher concentration to a solution of lower concentration through a semi-permeable membrane is termed as osmosis. Now next is hydrostatic pressure. The pressure exerted by a fluid at equilibrium at any point of time due to force of gravity is known as hydrostatic pressure. It is basically a push force, that is, it makes fluid move out of the capillaries. We can understand this by, let us consider this be a blood capillary. This is the fluid inside the blood capillary, and what the hydrostatic pressure really does is it makes the fluid move out of this into the interstitial spaces, which really manifests as edema. Next is oncotic pressure. The osmotic pressure generated due to the presence of plasma proteins is called oncotic pressure. It is basically a pull force that is makes fluid move inside the capillaries. It is mainly caused by albumin present in the blood. We can understand this by, let us consider this as a blood capillary, and this is the excess fluid in the interstitial spaces, and due to the oncotic pressure this fluid will move inside the blood capillary. Now next is the edema formation. Let us see what really edema is. The abnormal and excessive accumulation of extracellular fluid into the interstitial spaces is known as edema. This phenomenon is usually occurs when there is imbalance or impairment between the hydrostatic and oncotic pressure which are acting on the blood vessel. We can understand this by, let us consider this blood vessel. This is the arterial end of the blood vessel. This is the venous end, and the hydrostatic pressure is depicted by this red line, oblique red line, whereas it has pressure of 32 mmHg on the arterial end, and the pressure drops on the venous end as 12 mm of Hg, whereas the oncotic pressure, which is depicted by the straight blue line, is constant throughout the blood vessel, which is 25 mm of Hg. So when the blood moves through this blood capillary, the blood will initially move out of the blood vessel through these minute gaps into the interstitial spaces via increased hydrostatic pressure, which is 32 mm of Hg, and when it reaches the left side, which is the venous side, the fluid will again move into the blood vessel through the interstitial spaces because the oncotic pressure is really high on the left side. This is the normally how the blood moves through the blood vessels. Now let us understand the causes of edema. First is increase in hydrostatic pressure. Now this can be due to various reasons. Some of these are, when there is deep venous thrombosis, this leads to local increase in hydrostatic pressure, which leads to local edema. Or there may be congestive heart failure, which leads to systemic increase in hydrostatic pressure, which results in systemic edema. We can see through this image that there is increased hydrostatic pressure from its normal value. From 35 it is 46 on the right side, and on the venous side it is from 12 to 26. The hydrostatic pressure has really increased, whereas the oncotic pressure remains on its normal value. But due to increased hydrostatic pressure, the fluid moves out of the capillaries into the interstitial spaces, but is not really able to be reabsorbed because the oncotic pressure is really less in respect to the hydrostatic pressure. Therefore, the fluid remains trapped in the interstitial spaces, which manifests edema. Now next reason could be the decreased oncotic pressure. The decrease in plasma protein in blood really manifest decrease in oncotic pressure, and the plasma protein may be less due to the impairment in albumin synthesis, liver disease, malnutrition, nephrotic syndrome, etc. And from this diagram, you can see this that the hydrostatic pressure is in its normal value, that is 32 mmHg and 12 mmHg, but the oncotic pressure is really decreased because the albumin or the plasma protein is really decreased in the blood due to the various diseases we discussed before this. Now, because the oncotic pressure is really less, the fluid moves out of the blood vessel due to the hydrostatic pressure, but really is not moving inside or not being reabsorbed into the blood vessel because the oncotic pressure is really less and the hydrostatic pressure dominates the oncotic pressure. Therefore, the fluid remains trapped in the interstitial spaces. Therefore, edema is there. That is pretty much it. Thank you, everyone.
Hello everyone, my name is Anusham and my topic is body fluids and compartment. Now in this topic I'm going to be answering two main questions, that is definition of edema, what is the safety factor for edema protection. Now let us begin by understanding what edema actually is. Edema is an abnormal accumulation of fluid in the interstitial located beneath the skin and in the cavities of the body. Edema is the normal response of the body to the inflammation or the injury, for example, bee sting, twisted ankle, etc. Now, causes of edema. There are mainly five factors contributing to the formation of edema: increased hydrostatic pressure, reduced plasma oncotic pressure, increased blood vessel wall permeability, for example, inflammation, obstruction of fluid clearance in the lymphatic system, changes in the water retaining properties of the tissue themselves. Raised hydrostatic pressure often reflects retention of water and sodium by the kidney. Now, number one, increased capillary hydrostatic pressure. Rise in the hydrostatic pressure at the venular end of capillaries to a level more than plasma oncotic pressure. This leads to minimal or no reabsorption of fluid at venular end, thus ultimately leading to edema. Now, this is a diagram regarding to this, as at the atrial end we can see that the hydrostatic pressure is much more, thus causing the fluid to leak out, and in the venous end the plasma colloid osmotic pressure is less, and thus also causes fluid to leak out as it is not coming inside the venules. Reduce plasma oncotic pressure, reduce albumin synthesis in liver, protein malnutrition, causes fall in plasma oncotic pressure, which causes net movement of fluids into the interstitial tissues, thus leading to edema. Inflammation. Capillaries endothelial injury by toxin, histamine, anoxia, drugs leads to endothelial gap. This increases the capillary permeability to plasma proteins, thus causes decrease in plasma oncotic pressure, thus causing edema. This is a image regarding to this very thing that I explained in the previous slide. Now let us move forward. The fourth point, lymphatics obstruction, impaired lymphatic drainage which causes localized lymphedema. For example, pressure on main lymphatic ducts or inflammation of lymphatic vessels. Now this is a diagram. We can see when the fluid builds up, this causes obstruction, that is lymphatic malformation, or in normal way the lymphatic valves are acting normally and thus allowing the lymph to pass. But for example, in the B side that we can see slight impairment of lymphatic drainage in acute infection. As we can see, there is filarial parasite thus causing the obstruction and causing swelling of the lymphatic vessels. Now, sodium and water retention. In hypovolemia, there is renal vasoconstriction which decreases the GFR, ultimately leading to renal retention of sodium and water, thus causing edema. It also causes secretion of renin, which causes secretion of aldosterone, thus also causing the kidney to for renal retention of sodium and water, thus causing edema. There is increase in antidiuretic hormone, thus causing reabsorption of H2O, ultimately leading to renal retention of sodium and water, also causing edema. Now, classifications. It is classified into two main types, generalized and localized. Generalized edema is a condition when you notice swelling, puffiness, and water retention in various body parts, including your abdomen, arms, legs, face, and feet. Symptoms are bloating, tightening of skin, pitted skin. Condition leading to generalized edema are congestive heart failure, nephrotic syndrome, cirrhosis of liver. Now, edema causes generalized. There is a mnemonic for it: Hillary, H for heart failure, I for iatrogenic, L for liver causes, A for ADH increased, R for renal cause, and I for inadequate protein in blood. Localized edema defines as type of edema confined to a particular part organ of body, condition leading to localized edema, trauma, infection, lymphatic obstruction, venous obstruction. Edema is also classified into pitting and non-pitting. In pitting edema, we apply some pressure against a bony presence, and we can see uh, in the following slide in this picture that there is a pit, a hole like prominence against the bone, while in the other side, in the right side of this slide, we can see A and B images which are representing non-pitting edema. Major types. There are three major types: peripheral edema, pulmonary edema, cerebral edema. In peripheral edema, mainly edema occurs mainly in the legs, feet, ankles. The causes are hypertension, heart failure, pregnancy. In pulmonary edema, this is due to accumulation of fluids in lungs due to blockage of pulmonary veins. The main cause is malfunctioning of the left ventricle of the heart. Cerebral edema, fluids accumulates in the intracellular and extracellular spaces of the brains. Main cause, metabolic abnormality due to underlying diseases, oxygen deprivation at high altitude. Safety measures of edema: low compliance of interstitum. Initially, the interstitial space has low compliance, so small increase in fluid volume do not cause large increase in interstitial pressure, limiting fluid accumulation. Number 2, increased lymph flow. As interstitial fluid volume increases, lymph flow increases, which helps remove excess fluid from interstitial space and returns it to the bloodstream. Number 3, wash down of interstitial protein. Increased fluid filtration dilutes interstitial proteins, lowering the colloid osmotic pressure and reducing further fluid filtration into the interstitium. Number 4, capillary filtration coefficient reduction. When interstitial pressure increases, it can compress the capillaries, reducing the capillary filtration coefficient, which in turn decreases the rate of fluid filtration into the interstitial space. Negative interstitial pressure. The loose network of proteoglycan filaments in the interstitial space creates a slight negative pressure that helps pull fluid back into the capillaries. Number 6, safety valve function of the lymphatic system. The lymphatic system acts as a safety valve that increases lymphatic flow to remove excess interstitial fluid. When interstitial fluid pressure arises, lymphatic vessels open more widely, facilitating the removal of excess fluid. Number 7, increased plasma protein concentration. When fluid is lost from the plasma into the interstitial space, the concentration of plasma protein increases. This raises the plasma colloid osmotic pressure, which pulls fluid back into the capillaries from the interstitial space. Renal regulation of salt and water. The kidney plays a crucial role in regulating the body's fluid balance by adjusting the reabsorption and excretion of sodium and water. The kidney helps maintain plasma volume and osmotic balance, preventing excess fluid accumulation in the tissues. Now finally, some preventive measures toward edema. Regular monitoring. Regularly check for signs of swelling, especially in the extremities. Proper hydration. Maintain adequate hydration to support kidney function and prevent fluid retention. Low sodium diet. Reduce salt intake to minimize fluid retention and prevent exacerbation of edema. Elevate affected limbs. Elevate swollen limbs above the heart level to facilitate fluid return and reduce swelling. Compression garment. Use compression stocking or bandage to help reduce and prevent swelling. Exercise. Engage in regular physical activity to improve circulation and lymphatic drainage. Monitor weight. Regularly monitor weight for sudden changes which can indicate worsening fluid retention. Avoid prolonged standing or sitting. Take breaks to move around if you need to stand or sit for long period to prevent fluid accumulation.
We, Anamika and Ananya, roll number 8 and 9, are going to represent a seminar on the topic neuromuscular junction, which is topic number 16. The questions that should be addressed in this seminar are comparison between nerve action potential and the muscle action potential. And the second question is the pathogenesis of myasthenia gravis. First, we are going to discuss about motor end plate. The motor end plate, basically the nerve fibers, forms a complex of branching nerve terminals that invaginate into the surface of muscle fibers, but it lies outside the muscle fiber plasma membrane. This whole structure is called motor end plate. It is covered by one or more Schwann cells that insulate it from the surrounding fluids. Now, let's talk about the neuromuscular junction. First, anatomy of neuromuscular junction. The muscle fiber, when attaches with the axon forms a dilated axon terminal. This is known as the synaptic knob. The synaptic knob, when fuses with the muscle fiber, it leaves a gap between the two surfaces. These are known as synaptic cleft. So basically the neuromuscular junction contains a presynaptic membrane, a synaptic cleft and a postsynaptic membrane. The synaptic knob is covered by the Schwann cells and it contains the synaptic vesicles which contain acetylcholine. The muscle fiber, the sarcolemma of the muscle fiber further invaginates to form junctional folds, and these junctional folds are the regions of sarcolemma which have the nicotinic receptors which bind with the acetylcholine. The surface of the axon which releases the acetylcholine is known as the active zone. Now let's talk about the events during the transmission through neuromuscular junction. First, motor neuron action potential. That means the action potential ascends towards the axon terminal through the axon towards the synaptic knob. This action potential stimulates the voltage gated calcium channels present in the synaptic knob to enter calcium ions. These calcium ions fuse with the synaptic vesicles present in the synaptic knob and cause the release of acetylcholine in the synaptic cleft. This acetylcholine released in the synaptic cleft binds with the acetylcholine receptors present on the postsynaptic membrane, which is the muscle fiber, which is the sarcolemma of muscle fiber, and causes the opening of sodium channels. These sodium channels have 5 subunits, which include 2 alpha, 1 beta, 1 gamma, and 1 delta. The acetylcholine binds with the alpha subunit. That means two molecules of acetylcholine bind with 2 subunits of alpha subunit, and then the channel gets open and sodium gets transferred inside. Then this sodium which enters the sarcolemma into the muscle fiber causes local current between depolarized end plate and adjacent muscle plasma membrane. That means the sodium channel causes depolarization of the adjacent plasma membrane, and this causes the production of end plate potential. Further, propagation of action potential in the muscle fiber occurs through the opening of voltage gated sodium channels which are present on the plasma membrane. And during all this process, the acetylcholine released in the synaptic cleft is further degraded by acetylcholine esterase, and the choline is further utilized in the synaptic knob to produce more acetylcholine. Now, to summarize all the steps in the form of flowchart, first the action potential arises at the axon terminal. Then depolarization of the membrane of terminal buttons, that means synaptic knobs, occurs. Then voltage gated calcium channels open and calcium influx occurs into the terminal buttons. The calcium mediated exocytosis of acetylcholine vesicles occur and acetylcholine is released in the synaptic cleft. Further, this acetylcholine binds to its receptors in the end plate membrane and results in the sodium influx in local depolarization, and this results in the formation of end plate potential. The end plate potential brings membrane potential to a firing level and generates action potential. That means end plate potential shows summation and brings the level to the threshold level, and this generates action potential. Then the action potential spreads to the T tubules. Now we're going to discuss about acetylcholine formation and its release. The small vesicles of around 40 nanometer in size are formed by the Golgi apparatus in the cell body of motor neurons in the spinal cord. These vesicles are transported by exoplasm to the NMJ at the tip of peripheral nerve fibers. Acetylcholine is synthesized in the cytosol of the nerve fiber terminals, which are immediately transported through the membrane of the vesicles to the interior and stored in each vesicles. About 10,000 molecules of acetylcholine are present in one vesicle. Now the action potential arrives at the nerve terminal, which will open many calcium channels in the membrane. When the level of calcium increases, the rate of fusion of acetylcholine vesicles with the terminal membrane also increase. Then the fusion makes the vesicles rupture, allowing the exocytosis of the acetylcholine in the synaptic space. Now, after a few milliseconds, the acetylcholine is split by acetylcholine esterase into the acetate ion and the choline. Then this choline will be reabsorbed actively into the neural terminal to again form the new acetylcholine. For the continued function of NMJ, new vesicles to be reformed rapidly because the number of vesicles available in the nerve ending is sufficient to allow the transmission of only few thousand nerves to the muscle impulse.
Now, the drugs that enhance or block transmission at the neuromuscular junction. These are broadly divided into three categories. First, which stimulate the muscle fiber by acetylcholine-like action. Second, which stimulate the neuromuscular junction by inactivating acetylcholine esterase. Third, which block transmission at neuromuscular junction. The third category is further divided into presynaptic and postsynaptic. First are the drugs that stimulate the muscle fiber by acetylcholine-like action. Examples are metcholine, carbachol, and nicotine, which have the same effect as acetylcholine, but they are not destroyed by acetylcholine esterase, or they are destroyed so slowly that their actions persist. These drugs work by causing localized depolarization of muscle fiber where acetylcholine receptors are located. Thus, every time the muscle recovers, these depolarized area by the virtue of leaking ions initiate a new action potential. This causes a state of muscle spasm in the muscle fiber. Next are the drugs which stimulate the neuromuscular junction by inactivation of acetylcholine esterase. Examples include neostigmine and physostigmine, which work for a few hours, and diisopropyl fluorophosphate, which work for a few weeks, due to which it can be a lethal poison. These drugs causes the inactivation of acetylcholine esterase so that it can no longer hydrolyze acetylcholine. With each successive nerve impulse, acetylcholine accumulates and stimulates the muscle fiber repetitively, causes muscle spasm when even a small nerve impulse reaches the muscle fiber. Since acetylcholine esterase is not present for the hydrolysis of acetylcholine, repetitive nerve impulses causes the accumulation of acetylcholine, which can be a cause for the muscle spasm. It can also cause death due to laryngeal spasm, which smothers the person. These drugs are further divided into two categories, that is, reversible inactivation and irreversible inactivation. Reversible inactivation includes the drugs which compete with acetylcholine to bind to acetylcholine esterase. Thereby, they prevent the hydrolysis of acetylcholine by acetylcholine esterase. Thus, acetylcholine accumulated binds to its receptors. This finds its usefulness in diseases like myasthenia gravis. Examples of such drugs include neostigmine and physostigmine. Next are the drugs which show irreversible inactivation. These drugs bind to acetylcholine esterase very tightly. Lack of hydrolysis of acetylcholine causes sustained depolarization, resulting in no further response to subsequent nerve stimulus. Examples include organophosphorus compounds and nerve gases like atropine. Next category are the drugs that block transmission at neuromuscular junction. These are divided as presynaptic blockade and postsynaptic blockade. Presynaptic blockade includes botulinum toxin. Botulinum toxin is released by the bacterium Clostridium botulinum that causes paralytic disease botulism. This causes inactivation of synaptobremin, a vesicle membrane protein which is required for binding and fusion of acetylcholine vesicles with the plasma membrane of axon terminal. Thus, it helps in causing exocytosis of acetylcholine into the synaptic cleft. This inhibits the release of acetylcholine, resulting in cessation of muscle contraction. Next example in the presynaptic blockade category is the hemicholine. Hemicholine basically inhibits the choline uptake by presynaptic terminal, resulting in depletion of acetylcholine. As we know, acetylcholine esterase degrades the acetylcholine in the synaptic cleft into acetate and choline. This choline is taken up by the presynaptic terminal and further it is used to form more acetylcholine, but hemicholine inhibits the choline uptake. Thus this causes depletion of acetylcholine, and low acetylcholine results in decrease of end plate potential. Thus end plate potential is not able to reach to the threshold value and action potential cannot be formed. Next, postsynaptic blockade. Postsynaptic blockade includes competitive blockers and depolarizing blockers. Competitive blockers. Competitive blockers basically block the receptors on postsynaptic membrane. Examples are curare and galamine. They diffuse to the end plate potential and compete with acetylcholine for their receptors that are acetylcholine receptors. Thus, they do not get plus they are not hydrolyzed by the acetylcholine esterase. Next are the depolarizing blockers. Examples include succinylcholine choline and carbamyl choline. In these, acetylcholine is not hydrolyzed by acetylcholine esterase, therefore their action remains long-lasting. Maintained depolarization keeps the voltage-gated sodium channels in activated state and blocks subsequent action potential. Now, let's talk about the clinical application of neuromuscular junction. Let's talk about the disease myasthenia gravis. It is an autoimmune neuromuscular disorder. Etiology includes it results from a decrease in number of acetylcholine receptors on motor end plate due to production of circulating autoantibodies against these receptors. Postsynaptic folds in this condition are flattened or simplified, though acetylcholine is released normally, but the magnitude of end plate potential falls below the threshold and action potential is not generated since the acetylcholine receptors decrease in number. The functions of autoimmune antibodies produced include they compete with acetylcholine to bind with acetylcholine receptors, thus they block the receptors, they induce endocytosis of acetylcholine receptors, and they damage the postsynaptic membrane. As shown in this diagram, this is a normal neuromuscular junction. See the number of acetylcholine receptors present in the postsynaptic membrane. And this is the diagram of a neuromuscular junction of a patient of myasthenia gravis. Here the number of acetylcholine receptors on the postsynaptic membrane are decreased, plus the junctional folds are simplified and flattened. Features of the disease include fatigue. Patients show decremental response to repetitive nerve stimulus. That means the more they work, the more they get fatigued. Muscle weakness increases during prolonged usage. Diplopia and ptosis are early symptoms. Proximal limbs are commonly affected. This image shows a patient with ptosis. Treatments of the disease include administration of acetylcholine esterase inhibitors like neostigmine. Since acetylcholine esterase inhibitors will be present, more and more acetylcholine will be available to bind to its receptors. Next treatment could be thymectomy. Thymectomy will help in reducing the number of autoimmune antibodies produced. immunosuppression. It will decrease the number of autoantibodies produced. Next is plasmapheresis. Now, let's talk about the disease Lambert-Eaton syndrome. It is a presynaptic disorder due to production of autoantibodies against voltage-gated calcium channels. Since autoantibodies are produced against voltage-gated calcium channels, calcium influx decreases in presynaptic axon terminal, and this results in impaired acetylcholine release. Features of this disease include muscular weakness primarily in limb muscles. Patients show incremental response to repetitive nerve stimulus as calcium level raises with each action potential. The patients suffer fatigue within the morning hours, and when they work more, the fatigue decreases. With prolonged contraction, muscle strength increases.
Now we are going to discuss about action potential. The action potential is basically the electrical response of the membrane to a threshold or greater than threshold stimulus. The resting membrane potential is the relatively stable membrane potential inside the cell membrane of a cell in a quiescent or unstimulated state.
Good morning. My name is Tanya Sharma, roll number 108. My topic number is 26, erythrocyte indices A. Topic to be covered are: what is PCV and describe its clinical importance. Second, describe the morphology of red blood cells. Third, define the number of red blood cells and quantity of hemoglobin in the blood. First, packed cell volume, also called hematocrit. Packed cell volume is the fractional volume of blood that erythrocytes occupy. If a person has a PCV of 40, this means that 40% of blood volume is made up of cells and remainder is plasma. When blood is centrifuged in a tube, the red cells are packed together at the bottom of the tube by the centrifugal force as cells are heavier than plasma. Normal value in male average 42% and range from 38.6 to 48.6. In female, average value is 38 and range from 35 to 45%. Clinical importance: PCV is a reliable index of red cell population. It gives us useful information about the number of RBC in blood and their hemoglobin content. Low PCV value indicates the low number of RBC as seen in anemia, and in severe anemia it may fall as low as 10%, a value that is barely sufficient to sustain life. And high PCV value indicate high number of RBCs as seen in polycythemia, and during polycythemia hematocrit can rise to 65%. ये डायग्राम हमें ये दिखा रहा है कि जब हम किसी ब्लड सैंपल की सेंट्रीफ्यूगेशन कराते हैं तो उसमें 3 लेयर फॉर्म होती है. पहली लेयर में हमारे वाटर, प्रोटीन्स, न्यूट्रिएंट्स, हार्मोन्स प्रेजेंट होंगे. सेकेंड लेयर हमारी छोटी सी वाइट ब्लड सेल और प्लेटलेट फॉर्म करती है, और तीसरी लेयर हमारी रेड ब्लड सेल फॉर्म करती है. सेकेंड ट्यूब में आरबीसी का काउंट कम है जो हमें एनीमिया में देखने को मिलेगा, और थर्ड ट्यूब में आरबीसी का काउंट ज़्यादा है जो हमें पॉलीसाइथीमिया में देखने को मिलेगा. Second is morphology of red blood cell. Red blood cells are biconcave shaped cell. Their diameter is 7.8 micrometer and thickness 2.5 micrometer at the thickest point and 1 micrometer in the center. Average volume is 90 to 95 micrometer cube and they are non-nucleated cells with no mitochondria and no endoplasmic reticulum. They contain hemoglobin, and normal RBC count in male is 5 to 6 million per mm³ and in female 4.5 to 5 million per mm³. Lifespan of RBC is about 120 days. This diagram shows the various measurement of RBC: diameter 7.5 micrometer, thickness 2.5 at the thickest point, volume 90 micrometer cube. Third is number of red blood cells. नॉर्मल आरबीसी काउंट मेल में 5 to 6 मिलियन पर mm³ है और फीमेल में 4.5 to 5.5 मिलियन पर mm³ है। मेल में आरबीसी काउंट हमें ज़्यादा इसलिए देखने को मिलेगा क्योंकि उसमें टेस्टोस्टेरोन हार्मोन प्रेजेंट होता है जिनका स्टिमुलेटरी इफेक्ट होता है ऑन एरिथ्रोपोइटिन सिक्रीशन, जबकि फीमेल्स में एस्ट्रोजन हार्मोन प्रेजेंट होता है जिसका इनहिबिटरी इफेक्ट होता है ऑन सिक्रीशन ऑफ एरिथ्रोपोइटिन। इंक्रीज आरबीसी काउंट इज कॉल्ड पॉलीसाइथीमिया और इसका पहला फिजियोलॉजिकल कोज आएगा एट हाई एल्टीट्यूड। हाई एल्टीट्यूड पे आरबीसी की वैल्यू इंक्रीज हो जाती है in order to compensate for low partial pressure of oxygen at altitude। दूसरा हमारा न्यूबॉर्न में और उसमें इंक्रीज होता है बिकॉज दे हैज़ बीन लिविंग इन द स्टेट ऑफ रिलेटिव हाइपोक्सिया विच इज़ अ वेरी पोटेंट स्टिमुलस फॉर द सिक्रीशन ऑफ अर्थोपोइटिन हार्मोन। अर्थोपोइटिन हार्मोन बोन मैरो को स्टिमुलेट करता है और ज़्यादा से ज़्यादा आरबीसी की प्रोडक्शन करवाता है। दूसरा आ जाएगा हमारा पैथोलॉजिकल कोज जिसमें हमारा हीमो कंसनट्रेशन आ जाएगा जो हमें डायरिया और वोमिटिंग के केस में देखने को मिलेगा। सेकेंड इज डिक्रीज आरबीसी काउंट जो हमें एनीमिया में देखने को मिलेगा और प्रेगनेंसी में देखने को मिलेगा ड्यू टू हीमोडाइलेशन। एंड पैथोलॉजिकल इज एक्सेस एडिया सिक्रीशन जो हमें पोस्टीरियर पिट्यूटरी ट्यूमर में देखने को मिलता है। थर्ड इज क्वांटिटी ऑफ हीमोग्लोबिन इन आरबीसीज। नॉर्मल रेंज ऑफ एचपी इन मेल 13.5 to 17 gram per deciliter and in female 11.5 to 15.5 gram per deciliter. RBC have the ability to concentrate hemoglobin in cell fluid up to about 34 gram in each 100 ml of cells, and the concentration does not rise above this value because this is the metabolic limit of the cell's hemoglobin forming mechanism. Increased HP level males में ज़्यादा होगा as compared to females because ऑफ टेस्टोस्टेरोन हार्मोन जिसका स्टिमुलेटरी इफेक्ट होता है अर्थोपोइटिन सिक्रीशन। दूसरा न्यूबॉर्न्स। थर्ड इज हाई एल्टीट्यूड एंड डिक्रीज एचबी लेवल हमें फीमेल ड्यूरिंग प्रेगनेंसी ड्यू टू हीमोडाइलेशन एंड सेकेंड कॉज इज एनीमिया। थैंक यू।
Hello everyone, my name is Astha Sharma. Today our seminar topic is erythropoiesis and I will be covering stages of development of RBC. Genesis of blood cells. Blood cells begin their life in the bone marrow from single type of cell from which all the cells of the circulating blood are eventually derived, known as pluripotential hematopoietic stem cells. This is known as hemopoiesis. The intermediate stage of cell is very much like the pluripotential stem cells, even though they have already become committed to a particular line of cells and are called committed stem cells. The committed stem cells that produce erythrocytes is called colony forming unit erythrocyte. Growth and reproduction of different stem cells are controlled by multiple protein called growth inducers. Interleukin 3 promotes growth and reproduction of virtually all the different type of committed cells, whereas induced growth of only specific type of cells. The growth inducers promote growth but not differentiation of cell, which is the function of another set of protein called differentiation inducers. जैसे कि हम देख सकते हैं प्लूरिपोटेंशियल हेमाटोपोएटिक स्टेम सेल्स आगे जाके कॉलोनी फॉर्मिंग यूनिट स्प्लीन में डिफरेंशिएट होता है। उसके बाद कॉलोनी फॉर्मिंग यूनिट स्प्लीन आगे जाके बहुत सारे सेल्स में डिफरेंशिएट होता है जिसमें से कॉलोनी फॉर्मिंग यूनिट ब्लास्ट कॉलोनी फॉर्मिंग यूनिट एरिथ्रोसाइट्स बनाता है जिसके बाद एरिथ्रोसाइट्स की फॉर्मेशन होती है। Stages of differentiation of red blood cells. The first cell that be identified as the belonging of red blood cell series is proerythrocytes. The first generation cell are called basophil erythroblast. Polychromatophil erythroblast is the next generation where the hemoglobin first appears. Cell becomes filled with hemoglobin to the concentration about 34%. The nucleus condenses to the small size and its final remnant is absorbed or excreted from the cell. At the time, the endoplasmic reticulum is also absorbed. This stage is called reticulocytes because it contains small amount of basophilic material consisting of remnants of Golgi apparatus mitochondria and few other cytoplasmic organelles. During reticulocyte stage, the cell passes from bone marrow into the blood capillaries by diapdesis. Remaining basophilic material is the reticulocyte disappear normally in 1 to 2 days. The cell is then mature erythrocyte. Because of short life of reticulocyte, their concentration among all the RBCs is normally slightly less than 1%. Reticulocyte count is an important clinical indicator as the erythropoietic response to the treatment of anemia or blood loss. Erythropoietic response is good when the reticulocyte count is increased. Reticulocyte count do not increase in anemia. It indicates a lack of erythropoietic nutrient or aplastic anemia. स्टेजेस ऑफ डिफरेंशिएशन ऑफ आरबीसीज सबसे पहले एरिथ्रोपोइसिस में हमें प्रो एरिथ्रोब्लास्ट सेल दिखते हैं जिसके आगे बेसोफिलिक एरिथ्रोब्लास्ट की फॉर्मेशन होती है उसके आगे पॉलीक्रोमैटोफिल एरिथ्रोब्लास्ट की फॉर्मेशन होती है जिसमें 34% ऑफ हीमोग्लोबिन की कंसंट्रेशन होती है जिसके आगे ऑर्थोक्रोमैटिक एरिथ्रोब्लास्ट की फॉर्मेशन होती है जिससे आगे रेटिकुलोसाइट की फॉर्मेशन होती है जिसमें एंडोप्लाज्मिक रेटिकुलम रीएब्जॉर्ब होती है क्योंकि बेसोफिलिक मटेरियल और थोड़े बहुत रेमिनेंट्स गोल्जी एपरेटस माइटोकॉन्ड्रिया और साइटोप्लाज्मिक रेटिकुलम के पार्ट्स रह जाते हैं जिससे आगे जाके एरिथ्रोसाइट्स की फॉर्मेशन होती है थैंक यू
Hello everyone, my name is Arshita, roll number 15, and my topic is factors affecting erythropoiesis. Tissue oxygenation is the most essential regulator of RBC production. The rate of RBC production increases in the condition that decrease the quantity of oxygen transported to the tissues. The conditions that decrease the amount of oxygen that reaches the tissues can be anemia. Anemia में hemoglobin की concentration कम होने की वजह से ऑक्सीजन कैरिंग कैपेसिटी ब्लड की कम हो जाएगी डिस्ट्रक्शन ऑफ बोन मैरो के डिस्ट्रक्शन के केस में बोन मैरो की आरबीसी फॉर्मिंग कैपेसिटी डिक्रीज हो जाएगी हाई एल्टीट्यूड्स पे एटमॉस्फेरिक प्रेशर कम होगा जिसकी वजह से ब्लड की ऑक्सीजन कैरिंग कैपेसिटी कम हो जाएगी कार्डियक फेलियर एंड लंग डिजीजेस कार्डियक फेलियर के केस में ब्लड फ्लो डिक्रीज हो जाएगा जिसकी वजह से टिश्यूज के पास कम ऑक्सीजन पहुंचेगी ऑल दीज कंडीशंस रिजल्ट इन इंक्रीज इन आरबीसी प्रोडक्शन As we can see in this diagram, हेमेटोपोइटिक स्टेम सेल्स आरबीसीज की प्रोडक्शन में हेल्प करते हैं जो कि टिश्यू तक ऑक्सीजन को कैरी करते हैं अगर किसी फैक्टर की वजह से ये कैपेसिटी आरबीसीज की कम हो जाएगी और टिश्यू तक ऑक्सीजन नहीं पहुंचेगी तो फिर एरिथ्रोपोइटिन की प्रोडक्शन होगी मेनली किडनी से और कुछ अमाउंट में लीवर से भी और फिर एरिथ्रोपोइटिन हेमेटोपोइटिक स्टेम सेल्स पे जाके एक्ट करेगा जो कि आरबीसीज की प्रोडक्शन को इंक्रीज करेगा ताकि टिश्यूज तक सफिशिएंट अमाउंट में ऑक्सीजन पहुंच पाए Role of erythropoietin. The hormone erythropoietin is the principal stimulus for RBC production in low oxygen state. Hypoxia has little or no effect in absence of erythropoietin on RBC production. When the erythropoietin system is functional, hypoxia causes a marked increase in erythropoietin production and the erythropoietin in turn enhances RBC production until hypoxia is relieved. अगर एरिथ्रोपोइटिन नहीं होगा तो फिर हाइपोक्सिया आरबीसी की प्रोडक्शन पे ज्यादा इफेक्ट नहीं डाल पाएगा रोल ऑफ विटामिन B12 और फॉलिक एसिड आरबीसी की मैच्योरेशन के लिए जरूरी है both are essential for the formation of DNA as they are required for formation of thymidine triphosphate In absence of these vitamins, the erythroblastic cells of bone marrow fail to divide rapidly. ऐसी कंडीशन में जो आरबीसी प्रोड्यूस होते हैं वो नॉर्मल से लार्जर होते हैं साइज में और उनको हम मैक्रोसाइट्स बोलते हैं. ये इरेगुलर होते हैं और ओवल शेप के होते हैं. Such cells are capable of carrying oxygen, but they are more fragile and therefore have a short life as compared to normal RBC. Thank you.
So my topic is erythropoiesis, and the expected questions are sources of erythropoietin and the role of erythropoietin in erythropoiesis. Now, the sources of erythropoietin. It is produced mainly by the interstitial cells in the peritubular capillary bed of kidney, to some extent by JG cells and extraglomerular mesangial cell of kidney. So this means kidney is the main source of the erythropoietin, which is its contribution is about 90% and rest from the liver. The mechanism of action and function of erythropoietin. Erythropoietin acts on erythropoietin receptors, which is tyrosine kinase activity, which stimulate uh, the changes in the cell functions by the formation of signaling proteins in the similar way to that of growth hormone. The functions of erythropoietin. So main function of erythropoietin is to stimulate the formation of RBCs. I mean to stimulate erythropoiesis. So it will act on the progenitor cells during the development of the RBCs to stimulate their production. It will decrease the cell cycle length to enhance the mitosis so that the number of to increase the number of RBCs and to facilitate the maturation and hemoglobin synthesis in normoblast. Also, it ensures that the RBCs which are formed have enough hemoglobin to carry the oxygen, and it acts on the stem cells to promote their transformation toward erythroid series. It stimulates the release of immature erythrocyte into the circulation so that the maturation of the RBCs will be performed in a better way to form the erythrocyte. Role of erythropoietin in erythropoiesis. It is the principal stimulus for the RBC production in low oxygen state. It means hypoxic state में अगर पर्सन होगा तो एरिथ्रोपोइटिन ही उसका मेजर स्टिमुलेटर है, मेजर एंड प्रिंसिपल स्टिमुलेटर. एंड एरिथ्रोपोइटिन की एब्सेंस में हाइपोक्सिक कंडीशन में या तो बहुत ही कम या फिर आरबीसीज की प्रोडक्शन में बिल्कुल भी अफेक्ट नहीं होगा. यानी आरबीसीज की प्रोडक्शन उस हाइपोक्सिक कंडीशन में तब तक नहीं होगी जब तक एरिथ्रोपोइटिन अवेलेबल नहीं है. हाइपोक्सी कंडीशन में अगर हमें आरबीसीज की प्रोडक्शन करानी है तो हमें एरिथ्रोपोइटिन चाहिए. So erythropoietin enhance the RBC production until hypoxia is relieved, and erythropoietin stimulate the production of proerythroblasts from hematopoietic stem cells in bone marrow. The production of cells continue as long as the person remain in low oxidation state or until RBC have been produced to carry adequate of oxygen to tissues. It means जब तक हाइपोक्सिक कंडीशन ओवरकम नहीं हो जाती तब तक सेल्स की प्रोडक्शन को एरिथ्रोपोइटिन स्टिमुलेट करता है. And in the absence of erythropoietin, few RBCs are formed by bone marrow. And when the large quantity of erythropoietin form, अगर erythropoietin की अमाउंट ज़्यादा बढ़ जाती है तो RBCs की प्रोडक्शन 10 और उससे ज़्यादा टाइम से इंक्रीज हो जाती है. और अगर लेट्स अज्यूम अगर एरिथ्रोपोइटिन इतना इम्पॉर्टेंट है तो एरिथ्रोपोइटिन का सोर्स मेजर सोर्स किडनीज है. तो अगर किडनीज को रिमूव कर दिया जाता है दोनों किडनीज को, उसके बाद भी पर्सन बहुत रेयरली एनीमिक होगा क्योंकि 10% ऑफ कंट्रीब्यूशन जो कि लीवर से आ रहा था दैट इज सफिशिएंट टू कॉज वन थर्ड टू हाफ आरबीसी फॉर्मेशन needed by body. Here in this diagram, it indicates the function of erythropoietin mechanism. So it is stimulated by the decreased oxygen state, which further gives message to kidney to secrete the erythropoietin, and erythropoietin will further stimulate the erythropoietic stem cells to stimulate a proerythroblast and then RBC production, which will increase the tissue oxygen state. Thank you.